past few years, GLP-1 receptor agonists like Semaglutide, Wegovy, Ozempic, and Tirzepatide, Mounjaro, Zepbound have dominated headlines, social feeds, and celebrity interviews. These medicines have reshaped how clinicians approach obesity and diabetes, with dramatic weight losses reported in randomized trials. But public attention also revealed another pattern. A number of high-profile figures tried these injections and later stopped. Today, we'll examine who stopped, why they stopped, what real-world data and clinical trials say about stopping, and what practical, evidence-based steps viewers should consider if they're thinking about starting or stopping these drugs. High-visibility reports give us an unusually clear window into patient experience. Comedian Amy Schumer publicly described dramatic weight loss on semaglutide, but also debilitating nausea that forced her to discontinue the drug. She urged more honesty about side effects in public narratives. Her case highlights a core reality. Effectiveness and tolerability must be weighed together. Reality star Dolores Catania reported using Tirzepatide and later stopping after a cardiac procedure, describing both weight gain and emotional strain. This underscores medical context. Serious intercurrent procedures or new contraindications can require immediate reassessment and interruption of therapy. Brooks Nodder, Dancing with the Stars, said she tried semaglutide and stopped because nausea and fatigue interfered with the physical demands of performance. That example illuminates occupational constraints. People in physically demanding roles may find GI side effects unacceptable. Sharon Osbourne publicly noted she stopped after losing too much and deciding the trade-off wasn't right for her lifestyle. Chrissy Teigen has commented on mixed experiences as well, periods of benefit juxtaposed with psychological complexity regarding body image and medication. These candid accounts show that use is rarely a yes-no decision. It's a balance of clinical effect, quality of life, and personal goals. Beyond these named cases, media reporting and clinician forums document many patients who discontinue for side effects, cost and supply problems, or because life events change the risk-benefit calculation. The celebrity stories amplify what clinical registries are already showing. Discontinuation is common and multifactorial. What the trials and real-world data show: efficacy versus maintenance. Randomized controlled trials have produced striking efficacy data. High-dose semaglutide, the obesity dose marketed as Wegovy, produced substantial mean weight loss versus placebo, and Tirzepatide in head-to-head and parallel trials has produced even larger average reductions in body weight and waist circumference. These findings changed clinical practice because the magnitude of average weight loss exceeded previous medical therapies. However, randomized trials also show two recurrent themes important for viewers. One, sustained benefit often depends on continued therapy. Stop the drug, and weight frequently returns to baseline. And two, trial participants received structured behavioral support, diet counseling, physical activity guidance, and clinical monitoring, which contributed to outcomes. A key long-term follow-up of semaglutide participants demonstrated significant weight regain after withdrawal in many individuals, underscoring that pharmacotherapy is usually part of a longer-term strategy rather than a single cure. Real-world evidence mirrors trial insights, but adds practical constraints. Population datasets and conference reports indicate high early discontinuation rates, up to roughly half in some cohorts at 12 months, driven by GI side effects, cost and insurance coverage problems, supply shortages, and inadequate follow-up. These discontinuation rates are reflected in many public narratives. People start with optimism, encounter barriers, and stop. From a physiological standpoint, GLP-1s act on appetite, gastric emptying, and glucose handling. When the pharmacological signal is removed, appetite and gastric physiology revert, and absent persistent behavioral change, calorie intake often increases. That's why clinicians emphasize combining drug therapy with interventions that last beyond medication duration: nutrition counseling, exercise, sleep, and stress management. Gastrointestinal effects are the most common complaints: nausea, vomiting, diarrhea, constipation, and early satiety. Many clinicians manage these with slow uptitration of dose, dietary adjustments, smaller meals, low-fat choices, and symptom management. For a subset of patients, however, these symptoms are persistent or severe enough to necessitate discontinuation, exactly what public figures like Amy Schumer reported. Less common but serious risks are monitored by clinicians: acute pancreatitis, gallbladder disease or cholelithiasis, and rare case reports of serious GI events. Animal data raised concerns about C-cell thyroid tumors, a class signal that has warranted continued pharmacovigilance. Human relevance appears limited, but ongoing surveillance remains standard. In people with diabetes, some trials noted transient worsening of diabetic retinopathy in certain subgroups, so ophthalmological monitoring can be needed. Because side effects and rare risks exist, best practice is shared decision-making and baseline screening. Medical history, gallbladder disease, pancreatitis, personal or family thyroid cancer history, medication review for potential interactions, baseline labs if indicated, liver or pancreatic enzymes in some settings, and eye exams for patients with existing diabetic retinopathy. Clinicians also emphasize ensuring pregnancy avoidance during treatment because fetal safety has not been established. These safeguards are why medical supervision is essential. What typically happens after stopping? Physiology, weight trajectory, and emotional realities. When someone discontinues GLP-1 therapy, the pharmacological suppression of appetite and slowed gastric emptying ends. Many people report an increase in appetite and a return to prior eating patterns unless they have built compensatory behavior changes. Clinical follow-up literature shows that a substantial portion of lost weight is often regained if the medication isn't continued and behavioral changes are not maintained. That's the physiological reality behind many celebrity reports of weight regain. Emotionally, stopping can be complex. Patients may feel relief from side effects. Others may feel disappointment or shame if weight returns. Public figures face amplified psychosocial pressure because their weight and body changes are scrutinized. That can complicate decisions and how stories are shared publicly. For viewers, this underlines the need to approach any pharmacologic strategy with a long-term behavioral plan and psychological support when needed. Importantly, the decision to stop should be clinician-guided. Abrupt discontinuation without planning can lead to rebound hunger and weight regain. Many clinicians advise a transition plan: behavioral intensification, increased contact with dietitians or therapists, and close monitoring, rather than an unsupported stop. If side effects drive stopping, a clinician may advise slower dose adjustments, short breaks, or switching agents in carefully selected cases. These are medical decisions that warrant supervised care. The celebrity stop-start pattern feeds into larger questions: who should get priority access, how to ensure safe use, and how to manage public demand. High demand has historically created supply constraints and raised ethical questions about equitable access. Should scarce effective medications be prioritized for people with clinical indications, like type 2 diabetes, obesity with comorbidities, rather than for purely cosmetic use? Regulatory agencies and professional societies have urged stewardship and equitable distribution. Cost and insurance remain practical barriers. Even for insured patients, coverage for weight loss indications varies. Out-of-pocket costs can be prohibitive. Some institutions and insurers require documented attempts at lifestyle change before coverage. Others may offer patient assistance programs. Transparent conversations about expected duration, monitoring needs, and cost are crucial before starting. There's also a regulatory and safety angle. reports of patients sourcing drugs from unregulated compounding pharmacies or online markets prompted FDA warnings. These alternatives expose patients to dosing errors, contamination, and counterfeit products. The celebrity spotlight sometimes drives risky behavior, people seeking quick fixes without proper medical oversight, so public education plays a key role. Finally, the stop-start phenomenon reinforces the need for integrated care models, medication as one component in multidisciplinary programs that include nutritionists, exercise specialists, mental health professionals, and primary care or endocrinology follow-up. Such models aim to maximize benefit, troubleshoot side effects early, and build sustainable behavior change that can persist if medication is stopped.
Before considering GLP-1 therapy, talk to a qualified clinician, endocrinologist, or experienced weight management clinician. Discuss medical history, medications, pregnancy plans, family history of thyroid cancer, prior pancreatitis or gallbladder disease, and psychiatric history. Ask about baseline testing and monitoring plan, labs, eye exam if diabetic, and a plan for dose titration and side effect management. Understand coverage and cost. Check insurance policies, prior authorization criteria, and patient assistance programs. If you start therapy, follow a clinician's titration schedule and report GI symptoms promptly. Slower titration often improves tolerability. Pair medication with behavioral interventions, structured nutrition counseling, resistance training to preserve muscle, sleep optimization, and stress management strategies. These increase the chance that benefits persist if medication stops. Keep psychosocial support in the plan. Changes to weight and body image can trigger complex emotions. If you're thinking of stopping or have to stop, don't stop abruptly without clinician guidance. Ask for a taper or transition plan, or an intensified behavioral support plan. If serious side effects occur, seek immediate care. Prepare for possible weight regain. Ramp up behavioral supports, increase contact with dietitians or therapists, and consider alternate medical strategies if clinically indicated. Report any serious adverse events to your clinician and to pharmacovigilance systems. GLP-1 therapies are powerful clinical tools, but the celebrity stop-start stories remind us that medication is only one part of a complex picture. If you're curious, talk to a specialist, get fully informed, and plan for long-term support. Comment which celebrity case surprised you most and whether you want a deep dive comparison between semaglutide and tirzepatide.
Did you enjoy the video? Subscribe to our channel, Health and Wellness for All, for more tips and information. See you soon.